Hello everybody, can you see the slides?
Yes, sir.
Yes, sir.
Okay, so just for the recapitulation, the steps in the any areas of the clinical evaluation is remembering the causes, remembering the red flags, then little bit of history. In the history, not little bit, I should not be saying the little bit. History is most important. The general history, specific history, then examinations. In the examinations, the steps, then investigation and diagnostic. So first, let us remember the causes. So just now I discussed about the lumbar area because some of the causes are almost same like that because it is also the spine, cervical spine and the lumbar spine. Many things are common and similar. So number one cause was the back pain was disc degeneration. But here the disc degeneration is not very common in the cervical. Why? Because if you can remember in the lumbar when I discussed about the pathophysiology, about how the disc prolapse and how the internal disc disruption was happening, and this patient's actually age was younger. Why younger? Because nuclear material should be fluid and then only nuclear material will be leaking, within the layers of the annulus. Here also exactly the same pathophysiology is possible, but here the aging process. Can you remember the aging process of the lumbar disc? Aging process means the nucleus pulposus is becoming more of fibrotic, more of dehydrated, less fluid, so less chances to leak. Can you remember? That means if you're talking that somebody is aged, 60s, 70s, 80s, so there will be less chance to develop the internal disc disruption because discs are already dehydrated, it is becoming fibrotic. Same way, here also in the lumbar, in the cervical area, the disc becomes dehydrated much earlier. So here, normally in 30s, in 30s, 40s itself, so the disc gets dehydrated. It's become fibrotic. So it starts in the 30s and in 40s, most of the cervical disc becomes dehydrated and fibrotic. That means cervical internal disc disruption is much less common than the lumbar disc. Okay, so this is also another very important difference, but definitely that is one of the common causes. And as I told you, we cannot tell you the exact date, exact age, that at this age the aging process will start. At this age there will be, it varies from person to person, but it starts from 30s and by 40s, 50s, this becomes dehydrated. So the very less likely that there will be internal disc disruption. The second important cause was in the lumbar area was facet joint. Same way, cervical area also facet joint is one of the very common cause and the undiagnosed cause. In fact, cervical facet and the myofascial are much more common than the disc, internal disc disruption or disc degenerative related causes. So cervical facet, as I told you, much more mobile because our neck is much more mobile than the lumbar area. So here, the injuries and the related pain from the cervical arthropathies are, are very common, one of the very common causes of the neck pain. So exactly the pathophysiology are similar and the nerve also which carrying the pain are similar, but nomenclature is different. If you are remembering the lumbar L4-5 facet joint, I told you those who are thinking of future fellowship exams, this is a very common exam, very common, the questions. So my favorite question, that L4-5 facet joint innervated by medial branches from L4 and
L3.
L3, very good. L4 and L3 dorsal rami, L3 and L4 nerve root. So medial branch of dorsal rami of L3 and L4 nerve root. So if it is a cervical C4-5 facet joint, then what should be the R from they are coming?
Medial branches of C3 and C4.
C4 and C5.
If it is a 4-5 facet joint, what from they are becoming?
C4 and C5.
4 and 5, very good. That means it is nomenclature wise, innervation wise same, but why? Because in the lumbar, the L4 nerve root is lying below L4. Whereas in the cervical, C4 nerve root is lying above C4. So that is the reason of this, difference in the nomenclature. Otherwise, very simple way you can remember that a fascial joint, one nerve comes immediately above from that, and another is coming next to that. So in that way, so we should be remembering. So the cervical fascial joint, and another important difference in the cervical fascial joint, just now I told you, extension is not loading the joint much. It is the rotation and the lateral bending which loads the cervical fascial joint. Then very important common cause, in fact the second common cause is your myofascial. And in the myofascial, which muscles are more common? In fact, the myofascial pain, if you are considering the whole body, the commonest muscle is your trapezius. So trapezius myofascial pain is the very common, and is one of the common. Some says it is the commonest cause, some says it is the second common cause. So some literature says first, some say literature says second. So trapezius myofascial pain is one of the very common cause of the neck pain, and sometimes it is also called trapezitis. But trapezitis is basically a misnomer. There is no inflammation of the muscle. So there is basically the myofascial pain. There will be trigger zone, trigger area. There will be jump sign. Stretching of that will be painful. So all these features will be there in the myofascial pain. Apart from the trapezius, there are two other muscles which also can be, like your scalene muscles, like the splenius capitis. These are the few other muscles which can also be source of sometimes sternocleidomastoid. So these muscles can also be a source of myofascial pain, but the commonest one is the trapezius. Then the other causes, another important cause which was there is your interspinous ligament. Interspinous ligament, particularly the spines which are more kyphotic, that means C67 or C71. The C7 is the most, the protruded spinous process. So in these areas, the interspinous ligament sprain or enthesitis, that is also one of the common cause of the neck pain. So sometimes it is caused the whiplash injury. You must have read the whiplash injury means the car accident. When the car collides, there will be hyperflexion, then hyperextension. So this can cause the neck pain. That is one of the common cause of the injury. But again, if you are talking about you can remember I told also earlier that whenever you are talking, we are having a diagnosis. We try to make it two important areas of the diagnosis. One area is that where from the pain is coming, and second important area is why the pain is coming from that. So whiplash means it is an injury related pain, and where from the pain comes, most commonly they come from the facet joints, adjacent capsules of the facet joints, and other the muscle structures which can be the myofascial pain can also be there. So whiplash is not particularly pointing to a particular anatomical structures. Whiplash injury basically is a complex situations where many more structures, including sometimes the root also can be involved. So neurological structures might be also involved, but mostly it is the facet joint is the source of the pain, the whiplash injury. So keeping these few things in our mind, we'll be going. Red flag, again, I'll be coming to the subsequent slides to tell you the red flags, but it is also similar to that of the other spine pain, means lumbar spine pain. It is almost similar. But you have to remember one very important information just for the recapitulation, that the spinal cord ends at the level of the lower border of the L5. That means in the lumbosacral pathologies, there will be almost always lower motor neuron type of paralysis. Whereas in the cervical, it is either, it depends on which level. So this is not a very common thing, and it's a classical thing. That suppose somebody is having the mid-cervical level injuries, say for example C4, 5, 5, 6. So what will happen 6, 7? What will happen? There will be lower motor neuron type of paralysis of the upper limb, depending on the level where it is injury is there, and there will be upper motor neuron type of lesion of the lower limb. That means patient might be having the pain in both the upper limbs. Patient might be having the not much of pain, but some pain might be there in the lower limbs. But more important will be disturbance in the gait. Sometimes they might not be complaining any pain at all of the upper limb. But your role to examine it very nicely, very carefully. So that is the reason why if any patient is complaining of the lower back pain or gait disturbance, particularly if there is a difficulty in the walking, always examine the cervical spine nicely, because this is one of the very important areas. Cervical myelopathy is one of the common reasons why the patient might be having some gait disturbances, walking disturbances. Patient might not be able to walk with balance because of the motor weakness, and that motor weakness will be spastic weakness, means the legs will be spastic but weak because of the upper motor neural lesions. So this is one of the very typical feature of the cervical myelopathy, particularly if there is a chronic, the difference between the chronic disc disease or chronic narrowing of the canal. In the lumbar area, we have read it, lumbar canal, lumbar spinal canal stenosis or lumbar spinal stenosis. So how it appears? It appears with a neurogenic claudication. But when you are talking about the cervical area, here there is spinal cord. So what will happen here? There will be cervical myelopathy. There is no spinal cord at the level of the lumbosacral areas. So there is no question of, have you heard that lumbar myelopathy, sacral myelopathy? No, question do not arise because spinal cord has ended at the level of the L1. But we have heard about the cervical myelopathy, we have heard about what is the meaning of myelopathy. Myelopathy means it is a disease of the spinal cord. So when there is a chronic compression, there is a chronic stenosis and chronic compression of the spinal cord. So there will be development of the cervical myelopathy, and most commonly they present with the upper motor neural lesions, loss of reflexes of the upper limb, and the lower motor neural lesion, the increased muscle tone and the increased hyperreflexia, sometimes clonus, Babinski signs positive. So all these things will be seen in the cervical myelopathy. So coming back to causes, already I have told little bit, and causes would be coming with the structures, cervical spine structures. We've discussed fasciitis is one of the very common. Internal disc disruption is not that common. Prolapse intervertebral disc can also cause the neck pain, particularly because of the indentation of the dura. There might be neck pain, particularly the neck pain and the upper back pain combination is not uncommon in the cervical prolapse disc. And cervical radicular pain, radiculopathy normally presents with the hand pain, but if it is the upper, like say for example, C3-4 disc prolapse, patient might be presented with the neck pain and the shoulder pain. And also you have to remember the root value. I'll be talking about the dermatomal value of the cervical areas, like the lumbar areas. You have to remember that also. I'll be discussing when I'll be talking about the clinical evaluation part. Then the different muscles. Trapezius is the commonest one, but there are a few other muscles which can be so these are the anatomical source. And the pathological causes, it might be the spondyloarthropathies, it might be the degenerative conditions. Another very important things about the shoulder pain you have to remember about the referred pain. Referred pain means, this is again one of the very important rule to remember, that one joint, like if you're talking about the lower back, sacroiliac joint, heat should be always coming in a differential diagnosis. Same way, neck pain, shoulder should be coming in your differential diagnosis. Shoulder pain, any joint pain, can be referred proximal to the proximal neck joint and the distal neck joint. So shoulder pain, that means shoulder joint pain can be referred commonly up to the elbow and up to the neck. So same way, that means in the neck pain differential diagnosis, shoulder should be there. Another very important thing is your heart, lung, and the abdominal structures. Refer it to the shoulder or the neck. By innervation, they will be able to remember it. Just for the recapitulation, for the head and neck, the sympathetic innervation comes from T1 to T3. Upper limb, sympathetic innervations from T2 to T8. Thoracic viscera, T1 to T5. Abdominal viscera, T5 to T12. So if you are remembering these things, that means
Cannot hear you, sir.
No, cervical area is by up to thoracic viscera. It's more.
Sir, you muted
Sir, you are
yourself.
muted. Yes, sir.
Yes, I was disconnected. Let me share again. Can you see my slides now?
Yes, sir.
Did not hear anything what you said in last 1-2 minutes.
Pardon?
Did not hear anything what you said in last 1-2 minutes.
Okay, you couldn't hear me last 1-2 minutes?
Sir.
Okay. Yes. So what I was discussing was probably have you seen this red flag slide or this slide? So I was talking that any pain should be broadly classified into the intrinsic pain, means the pathology is there in that particular structure, or it can be extrinsic, or that is also called the referred pain. So here, when we are talking about the cervical area, so the causes means what are the anatomical sources, what are the pathophysiological reasons, and next is what are the extrinsic causes, means the pathology is not there in the structure of the neck, but it is coming from the other structures. So I was discussing about the sympathetic innervation. Because the sympathetic innervation is common with the thoracic abdominal structures, with the neck and the shoulder. So the thoracic pathologies and the abdominal pathologies, patient might feel pain in the neck and the shoulder. So shoulder joint itself, heart, the heart lung, that means thoracic viscera, and the abdominal viscera and the diaphragm itself, it can cause the referred pain. These are the extrinsic causes. And the intrinsic causes is the cervical spine itself and the myofascial pain. So we have to keep these things in our mind in the different causes. And next, the red flag. Red flag again is almost similar for the lower limb infection, tumor, and apart from that, if there is the progressive, the sensory and the motor, if there is any motor loss, and if there is any progressive sensory loss, so this should be kept in the mind. Apart from that, the bladder bowel here, like in the lumbar pathologies, so we can lumbosacral areas, we know that the pathology, it will be the parasympathetic nerve which might be getting damaged. But if there is any upper level, that means in the above the L2, both the sympathetic and the parasympathetic might be damaged, and depending upon which is damaged, so the symptoms will be different. If there are chest pathologies, so they should also be coming into the red flags. Like if there is a chest pain, if there is a tachycardia, if there is breathlessness or exertion, these also comes in the red flag. Whatever is there in the chest pathologies, if those are dangerous, so they will be coming in the red flag. And same way, if there is any abdominal pathologies which can be dangerous, also comes in the red flag. Horner syndrome is one of the red flag because some of the malignancies can produce the Horner syndrome. And rheumatoid arthritis, some books presents rheumatoid arthritis as a red flag. Means rheumatoid arthritis, if you can remember, most commonly involve the small joints of the hand and feet, but they can also involve the upper cervical spine. So rheumatoid arthritis involving the upper cervical spine can be a considered red flag by many literature. So they should be also considered as a red flag in the cervical spine. So keeping these things in our mind, causes and red flag, we'll now go into the history of general history of present illness. So first, after we are taking the chief complaint. So next is your history of present illness. In the history of present illness, we are having the intensity or the quantity. Then we are having the quality. I'm not just repeating it; it is same like the other areas: duration of pain, location of pain, radiation, aggravating relieving factor, associated neurodeficits, age of onset, and the chronicity. Other history, family history, occupational history, personal history, medical history, and psychological history. Psychological history is again very important. Many times we are missing it. in the examinations, after quickly going into the general examinations, anemia, cyanosis, all those things, then comes your inspection, palpation, range of movement, neurological examinations, and special test. So we'll be starting with the general examinations. The gait, I told you, one of the very important thing is because of the weakness of the lower limb, there might be the imbalance in walking, and many times quickly we have to go for the higher function test, whether the patient is oriented nicely or not, whether the talk is coherent or not, all those things. After that, we'll be coming with the inspection. Inspection again, whether head is held straight, how much is the looking the skin, how much the patient is having the muscles. I'll be telling you one important story that I saw a patient who is wearing the cervical collar, and I was asking that, okay, please open your cervical collar, otherwise how can I examine you? And you know what the patient told? I am wearing this for the last 10 years and I cannot sit straight, my head will be falling on one side if I'm opening it. I said, okay, my God, you are always continuously wearing it? He's telling him, okay, yes. And when ultimately, we reassured, and when he opened, we saw that almost all the, neck muscles are getting atrophied. So, all the very important things, not exactly related with the cervical spine, but related with the lumbar, sacral, lumbar and the cervical both. So that is, the use of cervical collar or the brace and belt for the chronic spinal pain, whether it is cervical or whether it is a lumbar, should be discouraged. This is one of the very, very bad practice. I should say extremely bad practice by almost most of the different specialties, BN orthopedicians, BN. It is recommended you just look at the literature, search the literature. How long a brace, belt or cervical collar are recommended, how long the patient should use. The answer is it should be used only for a short duration, and it should never be used in chronic pain. In acute pain, you can use for the short duration, but in chronic pain, you should never use. Why? Because basically, by putting in a cervical collar or by putting a brace or belt, what we are doing, we are limiting the movement. And if we are limiting the movement, we are basically causing the disuse atrophy of these muscles. So it is one of the very bad practice, and I'll be asking all of you, please take care and discourage the patient not to use it. And many times they are addicted to it. I should be feeling addicted. They're no, if I am wearing it, I cannot, it is my only support. So always tell that, okay, you should develop your natural support by making your muscles stronger, and that can be done with exercise. And at the same time, even if you are sitting straight, if you are walking, without our knowledge, our muscles, our paraspinal muscles, all are walking. They are doing exercise. So don't limit that exercise by putting in cervical collar or brace or belt. So coming back, inspection, you should be looking about the muscle wasting, whether the shoulders are symmetrical, particularly if there is a palsy of the 11th one, spinal accessory, there might be drooping, and sometimes spinal accessory is also causing the pain also. So now comes the palpation. Palpation. So here I have we have separated it as a palpation of the bony structures, palpation of the joints, palpation of the soft tissues, and starting from, I'm not going to the detail of that, palpation of the starting from the bony structure from the back, and starting from the occiput, we go to palpate each individual spinous process. Then when you're going laterally, we are going to palpate the facet joints, palpate the anterior bony structures, and you also palpate all the soft tissues. Soft tissues, the most important is the thyroid, the lymph nodes. Apart from that, the different muscles, particularly the painful areas, should gently be palpated. And palpation, again, like the back pain, what I told you, carries on the very important information about the location, the anatomical structure of the pain. Though sometimes it is difficult, like say for example, if somebody is having the tenderness in this, the paraspinal areas, so it can be facet joint, it can be myofascial pain, and sometimes it is difficult. So other tests is also important, but you should know that the area, the location, anatomical source might be, you can shortlist your differential diagnosis with palpation. Palpation is one of the very important steps. Then comes here the range of motion. As I already told you, that something is similar, like flexion, you are putting load on the disc. Extension, you are unloading the disc. But extension, for putting the load on the facet joint, you need to do the rotation and the lateral bending. And the range of movement is very important. Another reason why we do the range of movement is stretch the muscles. Particularly if you want to stretch the trapezius muscles, we should be flexing the neck to the other side so that you can stretch the trapezius muscle, and your myofascial pain, if it is from the trapezius, will be aggravated. Then comes the neurological examinations. The whole sets of neurological examinations should be done, and starting from the cranial nerves, because in the neck, cranial nerve examinations is very important. Then comes the sensory areas. Sensory areas, what I was telling you, that you have to remember the root values. So cervical C1, normally C1, dermatoma value is a very small area, nape of the neck. Then comes C2. C2 is the medial part, occiput. If you are putting the midline through the the occipital protuberance and the mastoid process, and if you are having the whole area one side, if you are dividing the medial one and the lateral one, the medial one is by the C2 and the lateral one closer to the mastoid process is your C3. Then C4 is from mastoid process up to the the shoulder. This area that means the lateral part of the neck and the shoulder. This is your C4. Then C5. If you are stretching our hand, then up to the elbow, lateral part of the arm is the C5. Then your lateral part of the forearm is your C6 up to the great toe. Then the middle finger and the adjacent areas is your C7, and then the medial aspect of the forearm along with the little finger is the C8, and the T1 is the inner aspect of the arm is your T1. So this dermatome should be remembered, and by looking at the dermatome values many times, it helps in diagnosing which root might be involved. Then after the sensory examinations, we have the motor examinations. Motor again, this is the gross things which you should be remembering. The neck flexion is your C2, neck lateral flexion or side flexion is your C3, shoulder elevation is your C4, the abduction of the shoulder is by the C5, the biceps, the flexion of the arm is the C6, the triceps is the extension of the arm, spanning the small fingers, grasping is your C8, and your T1 is the abductions. So these are the few things which we should be remembering for the motor. Then the jerk. In the jerk, 3 jerks are very commonly done. So these are the biceps, the brachioradialis, and the triceps. Biceps and brachioradialis are the 5, 6, but I remember in a simpler way: 5, 6, and 7. 5 for the biceps, 6 for the brachioradialis, and the 7 for the triceps. But you have to remember both for the biceps and the brachioradialis, 5, 6, both are there, and 7 is for the. Now we are coming to the special clinical examinations. Special clinical examinations, there are the few special clinical examinations we'll be showing you on the picture, and then I'll be calling one volunteer on which I'll be showing you the test again. So first is the Spalding maneuvers. Spalding maneuver, what we are doing? The passive lateral flexions means patient himself is not doing. You are doing. Flexing on one side, and if the test is positive, the patient will be having the neck pain as well as the radiating pain along the involved nerve root. It is most commonly done in the disc prolapse. So what is the mechanism of the pain? By laterally flexing, you are putting pressure on the facet joint, so there might be the neck pain. But more importantly, our foramens are getting narrowed, so the inflamed nerve root which will be impinged, and the radicular pain will be reproduced. So this is your Sparling's maneuver. So Sparling maneuver is one of the very commonly done, the test, special clinical test for the radicular pain. Then comes is your relief sign. Relief sign is you are putting your head on the either on the head or just back, and the pain will be relieved. Why the pain will be relieved? It means that when our hand is hanging, the nerve roots which are going to the hand, they are getting stressed, and the pain is going to increase. But when you are abducting, the nerve root is getting relaxed, and the pain will be relieved. And this is now the very common advice also. Whenever the person is telling, I'm having very severe pain, radicular pain going up to the leg, my hand, and one of the very common advice what we ask the patient to do is that when you'll be sleeping, please put your hand, over your head or upside, so that your pain will be relieved. Next is your neck distraction test. So what we are doing, we are pulling the neck by putting one pressure under the chin, another external occipital protuberance, and we are keeping it for some seconds, around 30 seconds, and the positive test will be patient will be having the less pain. So by distracting, basically relieving the pressure on the nerve root, and the patient's pain might be relieved. But it is again not specific of the the root. It can also be because of the facet also. Then is the valsalval maneuver. So you are putting pressure thumb there, or even just closing your mouth and then trying to exhale, so that your the thoracic pressure is going to increase, and that can reproduce the patient, which is the symptoms which is producing the.
Sir, your voice is not coming.
Again, internet issues. I don't know. Others are also not able to listen.
No, sir, we can hear. We can hear you.
We can hear you, sir.
So your internet connections might also be a problem. So valsalval maneuver, if there is a spinal canal stenosis, so then this can put the pressure on the, it can engorge the spinal vessels. It can also compromise the canal further, and the symptoms might be reproduced. So this is your valsalval test. Then is your Jackson compression test. Jackson compression test is we are combining the two.
I cannot hear you, sir. Just.
Shall I stop a while?
We can hear.
Can hear.
We can hear.
Okay. So the Jackson compression test is
Okay.
rotating the head, means the two movement combined. One is the rotation, another is the lateral flexion. I told you they are the two movements by which the cervical facet joint can be maximally compressed. So the Jackson compression test is mostly for the cervical facet joint, but this is also going to compromise the foramen because we are bending laterally. That means the Jackson compression test is also it's also going to reproduce the pain of the root pain, radicular pain. But if you're talking about, this question was asked by Lokesh or somebody else, that which test, Jackson compression test or this one, the Sparling test, which test is specific for which one? So the Sparling test is more for the root pain, but it can also aggravate the facet pain. But you can understand why. That's why today I started with the facet joint, these things. Because here we are going to compromise, we are compressing the foramen. But at the same time, lateral bending is going to put pressure on the facet joint. So facet pain also will be reproduced. But the facet pain is best reproduced by two movement combination. That is done in your Jackson compression test. So the Jackson compression test, we are doing the rotation plus lateral flexion. That means Jackson compression test is more specific for the facet, whereas the Sparling test is more specific for the root, but vice versa. Means Jackson compression test is also going to reproduce the radicular pain, as well as the Sparling test is also going to reproduce the facet joint pain. Then is your Lormead sign. So what is done here? So paresthesia and dysesthesia of the arms and the legs, particularly in the cervical, the myelopathy, if there is narrowing of the cervical canal, if you are flexing the cervical of the neck and keeping it for some time, then if there is, the cervical canal is compromised because of the many different reasons, so it will be reproduced. This is your Lormead sign. Actions maneuver, again, not specific of the, not for the cervical, but commonly done with the cervical. So what we are doing is, we are asking the patient to take the deep breath. This picture is not actually the fully correct. So the patient will be taking the full deep breath, and you are elevating the hand, and the patient's pulse is actually noted. The pulse will be the less will be feeble if the action test maneuver is positive. It is mostly seen in the thoracic outlet syndrome, not exactly for the neck pain, but it should be coming. So now I'll be coming to this algorithm, and then I'll be showing I'll be taking some of the question answers, and at the last I'll be showing some of the test. Though very simple, but still I'll be showing you on the volunteer. So first is, if the patient, like if you're remembering, when we are talking about the back pain algorithm, we are classifying broadly into two. One is predominant back pain, another is back pain with referred leg pain. So here we are having the similar kind of things. So here the neck pain with hand pain, but another very important areas here is that we are also having the headache. Cervicogenic headache. Cervicogenic headache is basically the neck pathologies, or the pain is referred to the head. So here another important column or category will be coming, that neck pain with headache. So three broad divisions: only or predominantly the neck pain, then your neck pain with hand pain, and the neck pain with headache that will be discussed later on. So if there is neck pain or predominant neck pain, whether it is an axial or midline, or whether it is a paramedian neck pain. If it is a midline neck pain, then whether the patient is having the tenderness over the spine. If the pain is poorly localized, midline tenderness, many times you have to remember that tenderness might not be visible in the IDD. In the IDD, because when you are palpating over the spinous process, you may not be able. Sometimes it is seen, but many times it is not seen. And if the patient is having the pain over the paramedian areas, because bilateral facet joint of the same segment can cause the axial neck pain, or in the same way like axial back pain. That means midline back pain or midline neck pain can be because of the bilateral facet joint on the same segment. If somebody is having the, say for example, the C3-4 and C5-6, then patient will be having the paramedian pain on either side. But if the patient is having on the same side, same level on either side, then patient might be having the midline pain. Bilateral facet joint should also be taken onto the in our considerations when the patient is having the midline pain. And the midline tenderness in between the spinous process, one of the very important cause already mentioned is your interspinous ligament. So there are the few things which you have to remember in the midline pain, axial pain. Out of these three, one is IDD. Flexor will be increasing the pain. We might be getting some tenderness over the spinous process, but mostly we don't. And the pain will be poorly localized because it is mediated by the sympathetic fibers. Next important is your bilateral facet joint. Here, the flexor will be relieving the pain. Junction test and other things, and the lateral flexion will be all producing the pain. But more importantly, you'll be getting the tenderness over the facet joints. And third one, the axial pain, is your interspinous ligament, where you'll be getting the tenderness in between the two spinous processes. So these are the only neck pain, where the pain is mostly midline. Then comes is your paramedian pain. Paramedian pain, two important. One is your unilateral facet joint. Another is your myofascial pain. They are the two common, and they are the two most common cause of the neck pain. So again, similar, if the patient is having the unilateral or unilateral paramedian pain, one-sided, the patient again, the few of the clinical test, the local palpation of the tenderness, and if it is a myofascial pain, almost similar. Sometimes only palpation is very difficult, but I do one test very simple when we are having the confusion. What is that? That you ask the patient, suppose the patient is having the pain on this side. Then what will you do? You'll be doing the stretching over the other side. If it is facet pain, what will happen? Pain will be relieved. And if it is a myofascial pain, mostly trapezius, the pain will be aggravated. Very simple. Just stretch the patient, the neck, stretch the neck, other side. If it is myofascial, pain will be aggravated. If the facet, pain will be relieved. Apart from that, all other tests, whatever is there, you have to do all those things. So this is your parapedian neck pain, the facet and the myofascial. Then comes is your neck pain with the hand pain. Neck pain where the hand pain is also there, and if the hand pain is the whole of the hand pain, then one of the very common reason is your CRPS, or also called the shoulder hand syndrome. Shoulder hand syndrome is another name for the the CRPS. RST is the earlier name. RST name is no longer used. Those many textbooks still mention about the RST means reflex sympathetic dystrophy. This nomenclature is no longer used. So, but CRPS and the shoulder hand syndrome, particularly in the orthopedic books, shoulder hand syndrome is one of the important areas. What will happen there? It will be global, because the sympathetic fibers are mostly the non-dermatomal, so vague, diffuse pain as a whole. Other than that, all other features of the CRPS will be there. If the patient pain is patchy, then again, one important question, or on the clinical examinations, you have to see whether the pain is following the dermatome or it is non-dermatomal. If it is dermatomal, then the most common cause is the prolapsed intervertebral disc. But the other causes of the dermatomal pattern pain, you have to think. What are those? One of them in the cervical and the thoracic area, the postoperative neuralgia is one of the very important areas. So postoperative neuralgia becoming diabetic mononeuropathy, which is involved in the nerve root, can also be one of the important differential diagnoses. I have seen some cases where the radicular pain is there, radiculopathy is there, but actually it was because of the diabetes. So these are the few things why the pain in the hand pain will be the dermatomal. Then if the hand pain is patchy and non-dermatomal, so there are two important possibilities. One important possibility is your effort pain coming from the cervical or the other in the neck pathologies which is coming, shoulder pain which is coming. So these are the effort pain. Apart from that, it can be because of the nerve entrapment. So the nerve entrapment, the different nerve entrapments are there. Common nerve entrapment, uncommon nerve entrapment. Common nerve entrapment is the carpal tunnel. Uncommon, there is a long list. So all these things can cause also the hand pain. So this is the neck pain with predominant hand pain, where the hand pain is either exclusive or predominant. Next slide is the neck pain, where the patient is also having the headache, and neck pathology is cause of the headache. So this is also called the cervicogenic headache. So here again, the cervical pathology, cervical structures, the most common one, which is the facet joint, mostly the C2, C3 facet joints. Apart from that, it can be myofascial pain, it can be occipital neuralgia, and sometimes migraines will be coming in your differential diagnosis. Definitely migraine is not called cervicogenic headache, but migraine is coming one of the very important differential diagnosis, because many of the migraine, the pain starts from the neck, and there is every reason why the migraine will not be confused with the cervicogenic headache. So it comes in a very important differential diagnosis. So diagnostic features are similar, but these are the few things where the neck pain is there with the headache. Some other causes of the neck pain with the headache might be the upper cervical, the disc pathologies might also cause the headache. But most common is your facet joint. Then comes your different occipital neuralgia, the greater occipital neuralgia, lesser occipital neuralgia, least occipital neuralgia. The least occipital nerve is also called the third occipital nerve. So these three types of neuralgias can produce the neck pain with the headache, and of course the myofascial pain. So this is the simple algorithm, and again, just to recapitulate, what are the common causes? Common causes is your myofascial, the facet joint, then comes is your disc will be coming less, and then there will be the occipital neuralgias, and there are a few common things which you'll be keeping in our mind. So now I'll be inviting questions from you, and after that we'll be taking some break, and then we'll be going for the demonstration on the volunteer. So if you have some questions, you can ask me, then we'll be taking some break, and then I'll be inviting volunteer.
Sir, what exactly happens in cervical myelopathy? Because there are symptoms of both upper motor neuron and lower motor neuron also.
Cervical myelopathy means the cord is going to get the damaged. So the fibers which is going there, and the motor nerve, so that the heart is there. So all are damaged. I mean, sensory and the motor all are damaged. The damage depends on how much the compression is there. The myelopathy is most common is your compressive myelopathies, but there are different other kind of myelopathies are there. It can be, the non-compressive myelopathies are also there. So I'm discussing about the commoner causes, that is your compressive myelopathies. So compressive myelopathies, again, the commonest is your disc prolapse, but there are a few other things are also there. So what happens here? Here the cervical cord is damaged. Cervical cord damage means the gray matter, the white matter. That means fibers which is passing to the cervical areas, going down to supply the lower limbs. So they might be damaged. So there will be upper motor neuron damage, and the fibers which are going to the hand. So upper motor neuron is ending and the lower motor neuron is starting. Those also might be getting damaged. So there will be a lower motor neuron lesion of the hand, depending on the which area is compressed, and that will be determining the which lower motor neuron will be damaged. Okay.
Sir, I have a small question.
Yes.
Sir, do we normally get a patient who has exclusively cervical radicular pain because of disc prolapse? Or is it like, patient normally has cervicomyelopathy along with obviously, upper limb radicular pain?
In cervical disc prolapse is not equal to cervical myelopathy. It depends on the type of prolapse. If the prolapse is compromising the canal and compressing the cord, then only there will be myelopathy. Otherwise, there will be radicular pain. If the prolapse is paramedian or if the foraminal, then what will happen? Only the root will be involved, and there will be no myelopathy.
So I just wanted to know, do we see patients who have, just the lateral part of the compression in the lateral part in the foramen?
I didn't understand your question.
Sir, I just wanted to know, do we get to see the patients who have exclusively radiculopathy? Because I didn't say just like.
We have to examine the patient. We have to examine the patient. We have to, if the patient is having the myelopathy, then there will be lower motor neuron, upper motor neuron reaction
in the
leg. So
leg.
that only tell you that there is myelopathy. Clinically, I'm talking about clinically. And if the patient is having no lower, the examination wise or symptom wise or sign wise, there is no, the leg symptoms. The patient is only having the hand symptoms. Then you have to clinically understand. Then this is predominantly radiculopathy without having
myelopathy. Got it, sir. Got it.
Ultimately, MRI will be telling you all. MRI will be telling you whether, where is the prolapse, whether it is only myelopathy. Sometimes if it is a big prolapse, then both is possible. If there is a big prolapse, then both will be myelopathy as well as the, the radiculopathy will be there.
Absolutely. Got it. Thank you, sir.
Excuse me, sir.
Yes.
The one who have given example that like at C4 lesion there will be C5 element damage, and so the bicep. In one class you have given explanation example like C4 lesion. At C4 lesion there will be CMN C5 lower motor neuron damage. So bicep jerk will be lost, and below that.
If a lesion is there at the level of the C4 or C4, then normally the one root, because in the cervical area it is normally 1 to 3, means upper cervical. If the lesion is at one level, then the nerve root which is going below becomes 1 to 3 level below. That means if the lesion is at the level of the C3-4, normally the most commonly it is the C5 which is getting damaged. Are you asking this question?
Yeah, so no, LMN and UMN. So element damage will be of C5.
Yes, means if the compression, if the cord is damaged at the level of the C4 or C3, C4, then the lower motor neuron lesion will be of the C5, and the C6 and below C7 will be upper motor neuron lesion.
So this I'm not able to understand why C6, C7, UMN.
If the lesion is that level, that will be involving the lower motor at that anterior horn, because that is coming out. So anterior horn of the C5 is situated at the level of the C4 or C3, C4. Again, I am repeating, C5 lower motor is coming from the C3, C4 level. So if there is a C3, C4 prolapse or C3, C4 any area in the compression, so the lower motor of that level is damaged. So now consider the C7. What is happening on the C6, C7? There is no lower motor at that level, but these fibers are coming down. This is the upper motor neuron is coming down, and they are ending at one level below. So the lower motor neuron of the C6 or C7 is one or two level below. So those lower motor are not damaged, but upper motor which is supplying those lower motor are damaged at the level of the C4-5. So at the level of the C7, C6, there will be upper motor neuron lesion and there will be lower motor neuron lesion at the level of the C5. Is it clear now? So not only for C6, C7, there will be lower motor neuron lesion of the L5 also, because L5 fibers are also coming down. That means below that level, all the level will be having the upper motor neuron lesion. Only the anterior horn cells coming from that level will be having the lower motor neuron lesion. Is it clear now?
Okay. Yes.
Okay.
Sir, I have a question.
Yes.
In the red flag list, you have mentioned that if the patient of rheumatoid arthritis coming with cervical spine involvement, we have to consider as a red flag.
Right.
So, all the patient of rheumatoid arthritis is considered red flag,
No,
or
no,
only the cervical involvement?
not all the patient with rheumatoid arthritis. If the patient is having the cervical spine involvement, because many of the times the cervical spine involvement can make the upper cervical spine unstable because of the rheumatological problems in the upper cervical spine. So that means rheumatology, somebody is having the rheumatoid arthritis and having the neck pain. We have to identify whether this neck pain is because of the rheumatoid arthritis or something else. If the neck pain is because of the rheumatoid arthritis, then it can be a red flag. You understand?
So, and if the mild involvement, the involvement of cervical spine, but no neck pain, so we consider it red flag or not?
No, not red flag.
Okay, sir. Thank you, sir.
So can it be clear from the history, like morning stiffness more than 30 minutes or 1 hour?
Definitely, history will be important. Other clinical features, so biological markers, even in the laboratory investigations. So all is going to help us in making the diagnosis that how much because rheumatoid arthritis and neck pain, these are the very common. Both are very common conditions. So many times they coexist. But you have to understand whether this is because of the rheumatoid arthritis, neck pain is because of the rheumatoid arthritis or not.
Okay.
Okay, so it is